Welcome to the Genesis Healthcare Podcast, where we go beyond the traditional office visit to explore what it truly means to live with optimal health. Each episode brings you candid conversations with our Genesis providers and featured guests from across the health and wellness space, covering everything from primary care and prevention to aesthetics and lifestyle optimization. Whether you're ready to take control of your health through a Genesis membership or explore treatment options to look and feel your best, we're here to guide you every step of the way. Ready to begin your journey to better? Visit thegenesisdifference.com to schedule your first appointment or aesthetic consult today.
I've got David Birchfield here with us today. That name used to scare me to death because it was another David Birchfield that was a pitcher in Little League, and he was a friend of mine growing up, and man, he could throw a fastball. So I asked David here when we first started as a patient if he was a pitcher in Little League, because I get the twitches because it always scared me because he was a little bit older than me too. So anyway. David has been a patient of mine for several years. How long does it go back?
Well, let's see. So probably even before you came here, I guess I was seeing you when you were with family physicians, and then when you moved here. So you've been here.
It's been 17 plus years.
So basically that whole time you've been my primary care.
Well, fantastic.
Yeah,
and
been
so
a long time.
Today we're going to be talking about some prostate issues and some men's health, some things that I think men don't really discuss a lot. And, fortunately, because you and I have a long history and a long rapport about talking about these issues, you've got your own personal history that I think is super important for people to also understand, because we look at prostate health and prostate cancer in particular, which is where we're going to dive in today. Prostate cancer has been that, it's slow growing. It's not that big a deal. You'll probably die from something else. That's what we were basically trained is right. Look at the PSAs, do the DREs, do this, do that. And then, we'll take the prostate out.
Yeah. If it gets serious, you just take it out. When it gets so bad, you just take it out. And
right. And
all's right in the world.
I'd love for you to kind of dive in a little bit more about, give me your history, your personal history, starting with your dad,
okay,
and then the ages and some of the things that would resonate with other men.
Yeah.
Okay.
So prostate cancer entered my life in 2006 when my dad was diagnosed. At the time he was 59. Had a cancer scare earlier in the year. They found a spot. He was a heavy smoker, smoked his entire life up till he died from the prostate cancer. But they found a spot on his lung that they thought was lung cancer. Went in February of that year, had full lung surgery, the hole open your side, do all that. Ended up being benign. Fast forward to midsummer that year of 2006, PSA was up. Probably in the 5 or 6 range at that point in time. Not real high for a 59-year-old, but enough. But the doctor said, hey, probably just an infection, residual infection from the surgeries you had earlier this year. Mm-hmm. We'll run a course of antibiotics and check it again.
Right.
A month later, it was up to 7-something. And so they said, okay, antibiotics haven't worked. Let's do a biopsy.
Okay.
And it came back, I'm trying to remember, Gleason 8, Gleason 9, most of them. Which in 2006, if they changed some of the Gleason scoring, years later, so probably would have been closer to Gleason 10.
And that basic Gleason for the
So for folks, when you get a Gleason score, you get 2 scores. You get a first number and a second number, and the lowest one is a 3. So a 3 plus 3 is a Gleason 6. So they look at each biopsy cell basically and say, okay, the lower the number, the less, I guess, I hate to use aggressive, but the more like a normal cell it looks. So the higher the number, so a 4 and a 5 look less like a normal prostate cell.
Right.
So the higher the number, the more,
okay.
I mean, it does turn towards aggressiveness, or at least the potential to be aggressive. So his was on the very high end, and that was in June, because I remember when it was because I was out of town. I was actually on a mission trip in outside of Tijuana in Mexico.
Okay.
He had his biopsy the week before. I knew he would get his results back. I was standing on a hill outside of Tijuana. We had just finished up at our campsite that day working on a house. And I stood on the side of a hill and got a cell phone bounce. I had my cell phone, and I got a hold of my wife, and she wouldn't answer my question, so I knew the answer. So I was on a hillside in Mexico when I found out my dad had prostate cancer. That was in June. In August, he had a full radical prostatectomy. They came out of that surgery. We knew it was bad when the doctor came out and he was in street clothes. Most doctors come straight out of surgery, and this doctor was in street clothes. They left us really doom and gloom. I mean, they told us kind of button things up and make sure he's got everything signed in maybe a year from now at most. Fortunately for us, he was somewhat of an exception. Everything they tried worked for a period of time. He lived for 13 years after that with side effects. He had a lot of the quality of life side effects that you would expect from that type of surgery, because they did, once they got in there and realized it was out of the prostate. So that's one of the things I like to talk about is, hey, the technology has improved greatly since then. So don't just, do the other stuff. Don't just do the digital exams. Don't just do the PSAs. Do MRIs and things like that. Back then, MRIs really weren't a thing for this. Mm-hmm. So they couldn't have looked then to find out it was out of the prostate. In today's world, he wouldn't have even had surgery. They would do radiation or something like that. So, but they got very aggressive with, once the doctor was in there and realized how significant it was, he tried to grab everything he could.
Sure.
But, so that obviously gets your ears going. His doctor was really good about saying, hey, you realize this makes you very much more susceptible to having it now that you've got a direct family member that's got it. So that was 2006. I was still young, I guess. About 2013, I think, is when I finally said, okay, let's do my first PSA. Two reasons. Number one, his history. Number two, part of the treatment that, I was doing here with you was I had very low testosterone. So I was doing testosterone replacement. And that can impact your PSA. So we wanted to kind of have that baseline.
Sure.
So I think my first PSA was 2.5, 2.6, somewhere in there, in 2013. So 13 years ago.
Which
so
is very typical.
Yeah, 43-year-old.
Yeah.
It's in the 0 to 4 range. Little high for the age.
Stayed right there for years.
For 6 years, it was an average. I ran the 6-year average, because one thing that when I went down this journey of monitoring everything, I keep spreadsheets. I'm a spreadsheet guy.
I remember.
So I monitor it. I've got every blood work I've ever had in a spreadsheet. So I know I can tell you anything, the high, the low, the average. My spreadsheet's set up where if I throw in something that's out of range, it flags it for me and things like that. So I've monitored it very closely. But then in 2019, we ran it and it hit 3. So we're like, okay. That, especially at that time too, what kind of added to that was, by that point in time, my dad's had progressed to, he was in hospice.
Right.
So, and to the point, prostate cancer is a mean, ugly cancer. When it metastasizes, a lot of times it gets to the bone.
Right.
And his was in the bone to the point where he was paralyzed. So when mine hit 3, we said, just do something. And that's where you had, Dr. Bush's name. And at that time he was in Chattanooga. You said, hey, he does these MRIs. So let's do the MRI to see.
So we didn't have that technology here.
No, nobody in this local area at that time was doing what they call, I think it's 3T MRIs, to look at the prostate specifically and check for lesions.
Sure.
And then they use this PIRAD scoring. So a PIRAD 1 through PIRAD 5, the higher the number, the more likely they expect it will be cancer.
Right.
Mine came back at a PIRAD 3, somewhat suspicious, but as Dr. Bush put it when I met with him after he did the MRI, you've got an ugly prostate. So he said, he found a couple of spots. He said, this is the one that's most concerning for me. He said, I need to bring you back and do a biopsy. And the difference between him, and again, this is where being in control of your own destiny, choosing him versus a standard provider that say your regular urologist wouldn't use typically technology like that at that time. They would have done 12 sticks, and they would have done any medications or anything. You'd have just gone into the fetal position in their office, and they would go transrectally and do 12 biopsies out of your prostate.
Okay.
And, you're talking an organ that's the size of a walnut, basically, about this size, and they're going to do 12 sticks.
That feels pretty good.
Yeah. And, but he does very specific. Mm-hmm. So he said, hey, this area is concerning. He uses that MRI, and he did the biopsy from that.
Okay.
So he did 3 sticks. A month or so goes by, and early May of 2019, I get the call, hey, it's cancer. Gleason 7. 3 plus 4. And it matters which number's first. Again, the lower the number, the more like a normal prostate cell it looks. So yes, you've got cancer, but it's not, I was 3 plus 4 with 15%, later downgraded to 10% as pattern 4.
Okay.
So I'd already done a lot of research, but I went into hyperdrive on research. I met with a radiation oncologist. I went to the proton therapy people down in Knoxville. I talked to Dr. Bush, and this is just when, in my opinion, active surveillance, they would call it, was really becoming prevalent. But it was scary to doctors because most of your urologists are you're positive, you've got prostate cancer, we need to put you in surgery. So most regular urologists, even a healthy, 49-year-old with a 3 plus 4 that would have the tendency not to be very aggressive, they would have done surgery a month later.
Mm-hmm. Well, I'm telling you, like for me, somebody who gets a diagnosis of prostate cancer later on in life, I'm like, you're fine. Somebody gets it early in their 40s, and I'm going, we need to do something like right now. Because you typically, from my standpoint and what I've seen clinically, is it's pretty aggressive if you're getting it early.
Yeah. Yeah. And that's where, so and it's scary. I mean, the C word scares us all, right?
Gosh.
I mean, we're just conditioned.
And your dad.
Yeah. With my dad, being, and that was so, there was a part of me that really wanted to just turn over and do something quickly just because I was watching the last 6 months of his life, and I get diagnosed with it. And by that point in time, I couldn't talk to him about it because he was in his final months, and, I wasn't going to burden him with that. But I was, a part of me was like, okay, once he's gone, I'm going to probably do something here. But then I stepped back and said, hey, you know what? I need to be more in control of my own destiny. This isn't a death sentence, I don't think. And, Dr. Bush, again, great resource. And, the difference with him and other doctors, and much like yourself, you let people steer the ship as much as they can themselves. Got them, of course. But, you're not just saying, you got to do this. He was very much, hey, you're young. This is not aggressive. Let's watch it. So he said, you need to get your PSA checked every 30 or every 90 to 6 months, every 90 days to 6 months. Probably have another biopsy at some point in time, do regular MRIs. So we did that. So I did, so that was 2019. And I came to you afterwards. We talked about it. And, I think you were a little leery at first because it was still, again, you're 49 and you've just been diagnosed with cancer, and you're telling me you're not going to treat it. So
it kind of gives me the heebie-jeebies when your dad dies early too. Mm-hmm. And we may have a little smoking history too.
Yep.
So, carbon monoxide is not good.
No.
Nicotine, not bad. Carbon monoxide mixed with it, not good.
Right.
So, especially with your urological care, you've got, you got blood in your urine and you smoke. It's like, uh-oh.
Yeah.
This is
right.
bladder cancer. Yeah. So smoking, carbon monoxide is really tough on a lot of C words, right?
Yeah.
So,
oh, yeah.
Anyway.
And that's why, going back, that'll take back a little history. So in 2010, when I was still a smoker, I was here in your office, in this office, my A1C came back real high. My cholesterol was really crappy. At that point in time, so I'm a 5'6" guy. I'm a short guy, but I weighed just over 200 at that point in time. And we kind of had one of those I called the come to Jesus meetings. He's like, how long do you really want to live? And
I don't really have those. Yeah.
But that was August of 2010, as I remember. And, you and I talked, and by November of that year, I had lost the first 35 pounds. By the following summer, I was mid 150, 155-ish. Wow. But the ironic thing was, for that whole first year of doing that, I was going to the gym. I would go to the gym. I would run 6 miles on the treadmill. I would go out the back door of the gym, and I would smoke a cigarette.
I know.
You
told me.
Yeah. So you kept saying, hey, when are you going to do that? So then, and my family remembers this very vividly because on June 28th of 2011, I finally decided I'm going to quit smoking. And at 8 o'clock that night on June 28th, I smoked what was my final cigarette. We went on a family beach trip the next week, and we didn't do another family beach trip for I think 3 or 4 years. And I was the reason. But no, so, so I'd done all that. So, luckily I'd done those right things before. Cause again, like you just said, if I were still sitting in 2019 as a smoker with a cancer diagnosis, the pathway could have been different.
Sure. And I believe it would have.
Yeah. I mean, cause I think
or a diabetic or both.
Right. Yeah. So,
I mean, like you cleaned up a lot of things.
Oh, yeah.
With there's not just the Tulsa procedure fixed your health,
Yeah.
right?
No.
It was the carbon monoxide abuse.
Right.
It was the affair with little Debbie, that I call all my diabetics, right? So, you did lifestyle modification and so many people, I think, were looking for that fix easy button in medicine.
Easy button.
And we push that button and go, well, my life should be better now because Joe said it was going to be better if I just took this metformin and had my Twinkie.
Right.
Right. And so you had to make that decision and, kind of like it or not. I mean, like your family history helped you make those decisions.
Yes, it did. I mean, I had just watching the final months of my dad's life, and I'm like, I've got to do things differently. So, and that's where, so from then I just watched everything, the PSA, and that's again, a lot of doctors will associate, hey, PSA does matter. So I don't want anybody watching this to mishear that. But PSA is not always the best prognostic indicator of whether a cancer will be aggressive or not.
Yeah, right.
Because I know plenty of people like my dad's. I mean, he had Gleason 9, 10 that say with a PSA that was never above 8.
Yeah.
And so, my PSA, it was rising over time. I had a urologist that I saw regularly, but I was rising with age, right? There wasn't, the thing with me that was unique is relative for my age and my PSA, my prostate was relatively small.
Right.
It was like 40 cc-ish. So it wasn't one of these, I didn't have the big 100 plus cc prostate that had all the BPH and stuff like that.
Right.
So now the downside to that is that means any tumors growing, if my prostate's not growing, that the tumor becomes a larger volume of the prostate.
Right.
So, when you do that all through the years and we watched it, finally what led me to where I did what I did in December, which the Tulsa procedure to address the prostate cancer was, I had an MRI done. It came back and I had one done 2023 and then a second one, the next one was in 2025. The 2025 one, ironically, didn't show the 2 lesions that I knew existed from the 2023 one, but showed a very significant lesion that wasn't there 2 years prior. And it was very near the edge of the prostate.
Okay.
So from that, I mean, the local doctor, again, wanted to go in and do, now the local doctors now, when they put you under and do a biopsy, which they do regularly now, but they don't just stick you 12 times. I had one biopsy under anesthesia here locally, 24 sticks. Mm-hmm. And 24 sticks to your prostate, it lives with you for quite a few days after. So I didn't necessarily want to do that. And Dr. Bush is really big about, hey, don't poke at the bear unless you need to poke the bear. It's kind of how I look at it. So I said, hey, I call his office. He does a lot of consulting. And I said, I want you to read my MRI. So this was July of 2025. Scheduled I guess late July we talked. He said, he looked at the MRI and he said, hey, I need a better image. Let's put it that way. And one of the things that your standard urologist and healthcare providers don't do before an MRI of the prostate is make you do an enema. And again, it's uncomfortable stuff to talk about, but gas is your enemy when it comes to reading those type of biopsy or those type of MRIs.
Okay.
No place locally that I've been experienced with makes you do an enema before those procedures. So he said, hey, he said, some of the stuff that I think they're seeing is maybe gas bubbles. So he said, come to my office. It'll be out of pocket, but it wasn't too expensive. I think his MRI was under $2,000. I don't remember the exact number, but you do a full prep before to make sure there's no gas there. And he read it and we looked at it and said, hey, there's a good sized tumor here, but it's the tumor he had originally found. He said, yes, it's grown. He said, your prostate's now about 46 cc's. So it's grown some over the years, but it's not
bad.
Not abnormal for your age. But one of the things that he said that he does now that he hadn't done with mine then is there's what they call a decipher genomic testing that they can do on your biopsies.
Okay.
I'm like, hey, we don't know what my biopsy was at this point in time. That would have been 6 years before. How long do they keep those slides? He said, oh, they keep them 10 years. So while we're sitting in his office, he calls the group that had the biopsy slides and says, hey, I've got David Birchfield sitting here. Do you still have it? No? Oh, yeah. We send it off to for this genomic testing.
Yeah.
So they throw your biopsy results into this system, and it's up against all the hundreds of thousands of results they've got in their system. And it comes back with all these different things.
Okay.
They give you a score. My score was relatively low, which is a good thing. But then they do these individual things. They look at the various pathways and stuff that cancers can grow and mutate and stuff like that. And there were a couple of things where I was in the 100th percentile, meaning my tumor scored differently than all of the other hundreds of thousands of tumors in their database. There was one I was 100%, and there was one I was 98.
I don't think that's a good thing.
No, it's not. And that's where, and the other thing again, so when you get your results, they call you, and his wife, Kathy, goes over the results with you.
Uh-huh.
And she said, these results right here, these two things specifically, this means you're not a matter of if you'll treat your cancer. It's a matter of when.
Wow.
And when she said that, I mean, I didn't hesitate. I had studied enough on the procedure he does and knew enough about everything of if it escapes, you're in a different world. Once it moves out of the prostate, you're in a different world. I didn't want to get there. So I said, when's your next available? And his next available was December 16th, which happens to be my birthday. So I said, happy birthday to me. So we scheduled it. And December, I went in Alpharetta, Georgia, and did what they call the Tulsa Pro procedure.
Okay. Now, that is fantastic history up to our Tulsa procedure. So could you maybe go through a couple things as far as treatment modalities that were given to you, possibilities, given where you are at a Gleason 7 and increase in volume. And then I'd like for you to maybe go through a little bit about what this Tulsa procedure kind of is. And, and then we'll kind of go into maybe some of the insurance snafus associated with it after that.
Okay. I mean, from a treatment modality perspective, most of your urologists, their only treatment option they want to look at is surgery.
Okay.
Let's do a radical prostatectomy.
Okay.
We know insurance is paid for it. Oh, you'll be fine. Yes, there's some potential for quality of life side effects, but the robotic procedure, the robotic's done it thousands of times. You'll be fine.
And it's financially viable.
Yeah. Yeah. I mean, because the insurance is going to cover it. I mean, it's the standard of care still for prostate cancer, regardless of Gleason score, regardless of age. It's still the standard of care is let's take your prostate out.
Sure.
And for you can go look at a chart, go look up the prostate, where it sits, what it's attached to, and just imagine what happens if there's a little slip or anything in that surgery, what is impacted.
Well, even with
the best case,
you're
still typically months, if not years away from having erectile function, going without pads or diapers. I mean, those are all things, and, a lot of the statistics that I read up on say, they're low end statistics say the average 10 to 15% of guys regret having a radical prostatectomy. Some unofficial surveys say that's probably 40% or more. Mm-hmm. And a lot of I'm on a lot of boards and stuff online again, because I'm controlling my own destiny.
Sure.
So I studied a lot, and, there's very few guys out there that were my age that made those decisions that felt like that was the right. So that's why I knew when Dr. Bush had first treated me in 2019, doing the MRI and everything, I knew he was looking at this. Because at that time, the Tulsa procedure was relatively new.
It was over in Belgium,
in the U.S. He was doing it in Belgium. Right. He was actually sending patients over there to doctors where he ultimately went. I think that's where he went and learned it. And then, he worked through various things and opened the office. That's when he moved from Chattanooga to Alpharetta, was later in 2019. So late that year, early 2020 is when he actually opened that office and started to do them here in the U.S. And it's, that gets into, yes, the insurance will pay for a radical prostatectomy. They don't think about quality of life after it's the standard of care.
Sure.
So I'm like, I mean, again, having a first degree relative that went through it and watching the potential there of, I'm like, I want to do something different.
And we're in our early 50s at this point.
I mean, there's a lot of life left. And, so there's several newer things out there that are more minimally invasive than surgery. This one I felt comfortable with just from what I studied about it, talking to him about it. The nice thing, just like if there's something that you've treated somebody for, you've got people that, hey, if you need to talk to somebody about this, you can call so-and-so. Same thing with him. He said, hey, here's guys that have given me the okay for you sharing their names that you can call and talk to. Started emailing with a couple of folks and felt real good about the impact it would have on life, or lack of impact, I should say. So I said, that's what I'm going to do when I finally have to treat. And I'd actually likely made that decision. I'd talked to my wife a lot about it before even knowing that I needed to treat it, that if I ever went down that path, it's going to be a financial hit because, by the way, insurances still don't pay for it much.
Right.
But that would be what I would do just because it gives me a better chance coming out with quality of life on the other side.
Yeah. And so the procedure, can you describe what the procedure is?
Yeah. So for those that get uncomfortable, squeamish, just be ready. Here we go. But I mean, it's done under full anesthesia. You go to their office, again, do full bowel prep. I mean, and you start that the day before. So it's like you're almost prepping for a colonoscopy the day before.
Okay.
So just get comfortable with being in the bathroom because that's what you're going to do the day before. Yeah. You're not going to go out and have this big celebratory dinner before.
I'm fairly comfortable there.
Yeah. So, so then you go to the office, they hook you up, they do anesthesia. And while you're under, I mean, they basically insert a rod through your urethra and do basically an ablation of the prostate. And they can do very focal. So some guys just choose to do a focal. I've got one lesion and I want them to hit it and get out. So that's an option. In my case, the size of my tumor, the size of my prostate, we decided we went close to full ablation, about 85%. It was his estimate of what he ablated. So it goes in and
just heats it up.
Heats it up. And what he does, and again, this is all MR guided too, right? So he used the MRI he did from August of last year, planned it in the system, but then actually uses the real-time MRI while you're in it. So you're in the MRI machine while they're doing it. And he does one pass and then waits about 30 minutes, looks at the MRI, looks for any spots that maybe look a little lighter and does a second pass, concentrating very specifically on any areas that he needs to. So you're under, again, at 50, I turned 56 that day. It was the longest I'd ever been under anesthesia in my life. I was under anesthesia for 4.5 hours. Yeah. So, but then you come out of it, the downside is you got a catheter, but I mean, I went back to my hotel that night. I could eat, do what I wanted to do. The next morning they see you and then they send you home. Huh. You wear a catheter for 14 days, which, that was what I was most worried about. I wasn't worried about the procedure itself. I was really nervous about the catheter. It was less of an issue than I thought. Now, some guys have, they get uncomfortable.
Right.
But, I didn't have that problem. Luckily, they tell you the procedure to take it out at home. So on day 14, you do that and it's a non-issue.
Okay.
And, that's also a day of concern too, right? Because even this, there's still the risk of, incontinence. Mm-hmm. So when that catheter comes out, you're gonna know pretty quick.
Yeah, that muscle hadn't been working for 14 days.
Correct. But I did for a day or two. I did a pad just to be safe. But by 2 days after the procedure, I didn't need anything.
Okay. Well, that's pretty awesome, really. So you're what, 8-9 weeks out now?
Oh, almost 3 months.
3 months, really?
Yeah, December 16th. So
okay. So you said it was right around 6 or 7 weeks where you were like, best thing ever.
Mm-hmm.
So no, zero incontinence,
Zero incontinence.
no erection issues.
I knew before my catheter came out that I woke up very uncomfortable one morning with the catheter still in. So I knew before the catheter came out that I was going to be okay there.
Okay.
It was uncomfortable, but it was also it was a happy, but it was a little terrifying. But it was very uncomfortable. But you also knew then, hey, and again, this procedure, which I guided myself to, I'll say it that way, because I made the choice to pay out of pocket for something that would give me a better chance at quality of life coming out of the backside of it.
Well, and that, bleeding into a good transition into what we do and why we do what we do is, I really don't like the fact that insurance dictates our plan of care.
Mm-hmm. Oh yeah, it's horrible
because you and I have been together for a long time, and insurance was in the middle and in the room with us. Mm-hmm. I had to think about, okay, well, you had a plan with United Healthcare, you had it with Blue Cross, and have had several different plans throughout the years, all pretty good insurance. You had really good insurance, but they were always sitting in the room with us, and I was thinking about those decisions with that insurance company in mind,
right?
And so, when we start talking about a significant financial outlay versus it getting covered by insurance, that's where you weigh, all right, it is the squeeze worth
the juice?
The juice,
yeah.
It's kind of like, this one right here, I mean, the squeeze and the juice, it's significant quality of life.
Oh, yeah.
Because, we don't talk enough, I don't think, about men's health from a prostate standpoint and prostate health and urinating at night and getting a good night's sleep and all of those things. And so when you're talking about, having to wear pads or diapers or, having to use instruments or injections to have intimacy, we just it's kind of almost faux pas.
Oh yeah,
right. Well, that's how we all got here too. By the way, so it's one of those things where I'm glad we were able to discuss this procedure or your health in that. But it really, like, if we're going to allow a third party to make up our decisions for your health, that's going to be really tough for me.
Oh yeah,
and that's why I had to leave it, and I had to just say, I cannot listen to insurance dictate your care anymore, or tell me what to do.
Right. Yeah, and it's hard to make those. Again, luckily I'm fortunate enough to be in a position where I could choose a different path financially. But so many people, even people in really good jobs, a lot of them live paycheck to paycheck. So they're going to have to do whatever the insurance dictates that will be covered.
Right.
Because they won't have another choice. And I just made the decision years ago. I said, I will be in control of my destiny as much as I can. And I knew going in that insurance wouldn't likely pay for it. Now I tried, I went through the appeals process and everything. And what I found is my specific insurance, if I had done radiation first, I think is what they told me, and I was using this as a salvage treatment, they would cover it.
You don't really want to hear the word salvage.
No.
In a medical procedure.
No, you don't. And you don't want to think about,
I've had one.
And when you think about radiation in that area, radiation is one of those nice gifts that, hey, it fixes it right then, but the side effects of radiation you don't know for years. So insurance would have paid for me to do this if I had gone in at 49 and let some doctor radiate the prostate bed, meaning that likely bowel and bladder and other issues 5 to 10 years later would most likely guaranteed to happen. Right. They would have then paid for this procedure. By that point in time, I probably wouldn't care enough to just go ahead and just take it out. Tulsa probably wouldn't be an option at that point in time because
you were already urinating on yourself.
You're already having the side effects. So,
yeah. And I do think that, you taking the time and effort to look at data and look at, your quality of life and the pluses and minuses of if this, then this, if this, then this. That's so important, I think, for me as a provider to hear from you as a patient and saying, this guy's, I mean, like, you took the ball and ran with it since day one.
Right. And you let me do that.
Well, but there was a lot of times where we kind of went toe to toe on a lot of things. I mean, smoking was one of them. Yep. Sodas was another one. Or blood sugar and all of those things. And so, like, I don't back up very much when it comes to what I think is right. But there was times where I was like, "You want to try this medicine? Do you want to try this medicine? Do you want to try this medicine?" But a lot of what I really appreciate about you is you coming in and showing me your PSA for the last 10 years. On a graph. Yeah. And so that I was like, okay, well, fantastic. I can look all that up. It's going to take me about 10 minutes, but it's just fantastic to have people, as a provider, to have people that actually just care about their own health. Mm-hmm. It makes my job so much easier. Yeah. Because I can just go, I don't think I do that. Right. Or that's a great idea. Or this guy right over here is the best. Yeah. Go here, go here, go here. I really like this guy.
And being able to have those open conversations with you was great. Yeah. I mean, I had to go through a couple of urologists before I could get a urologist bought in as to why I wasn't treating the cancer when they diagnosed it. Right. So, you were a little questionable just because of my dad. Yeah. But I guess, again, my data helped, hey, I think, absolutely. I think this is a better path. I'll address it at some point in time if I need to, but right now, all of the data I was able to gather would say, this isn't something that I need to worry about for a while.
You got so many times we are trained to be the authority, and we forget that you're the one, this is your health.
Yeah, I got to go home and live with it. It's not mine. Yeah, I got to go home and live with
whatever. Like, I can give you the data, and I can tell you what I would recommend you do. But at the end of the day, you got to take the pill, or you got to eat the eggs instead of the Twinkie, or, whatever it is. I mean, like, you still have to live your life, and it's your health, not mine. And if I give you the data and you choose to go this way, that's fine. You go this way, that's fine. It's still your health. And I don't think a lot of folks in life really kind of go, well, that's his choice.
No, we're trained not to, right? We're trained not to. With insurance especially, you're trained to just fall in line and do, this is the best thing for you. And anymore, insurance companies, it's not doctors and stuff at insurance companies making these decisions. They're making financial decisions. They're not making healthcare decisions. And that's the system you're working against, which is why, I carry regular healthcare coverage just because I've got a family and we've had some things and we need that. Sure. But I also pay the fee to come here monthly because I value that. And
it's the benefit.
It is. I mean, again, and I'm a frugal guy. I know. If I didn't think I was getting benefited out of it, I wouldn't do it. So, but I like having that ability. And your office I feel like they genuinely care, right? Yeah. And but it's not, you're not dictatorial. Like, I mean, again, when I go back to the urologist, when there were several urologists that when they found out I had cancer and didn't want to treat it immediately, they weren't sure if they could even keep me as a patient. Yeah. You're going against the norm. That's foreign to us. Yeah. Because they're just so used to society falling in order, I guess. And that's what's wrong with healthcare as a whole. And that's what puts guys like us, guys that know this, but maybe don't have the financial means, they may just sit back and let the cancer grow versus having the surgery just because they know the side effects, but they can't afford the other side of it, right? So that's the big thing with this is, and I don't mean it bad as it might sound, but, we make a lot of hoopla that say about cancers that affect women. Breast cancer, you hear a whole lot about it. Prostate cancer, and some of that probably men we bring on ourselves, it's getting more noticeable. But it's hard to talk about. Sure. Because of what it impacts and what it can affect. But I think we got to do that because we got to get these people that are making these decisions understanding, hey, there's alternatives to that. And yeah, there's risk of recurrence, in my opinion, even with a radical prostatectomy, if you have a high Gleason score, there's still the potential for recurrence. You can have one little cancer cell out there that eventually shows up metastasizing somewhere else.
So don't smoke and become diabetic.
Correct. Again, it's if you're in control of your own destiny, I know the things that will help me prevent at least the potential for recurrence. No guarantees, but this, I think, yes. So I still have a prostate. I still have prostate cells. There's still the potential there could be some cancer in what's left of my prostate.
So let's go into that just a titch. What's post-operative care from here on out? We're going to do MRIs routinely?
Do, for the first year, PSA every 3, 6, 9, 12 months.
Right.
Just to see. Now, so in my first one will be, I'll do my blood draw next week. Okay. So a week from now, I'll know what my first post-PSA procedure is. It's typically somewhere between 70 to 90% lower than it was going in. So that'd be kind of the first indicator of, hey, things are good. Do that again at 6 months, 9 months, 12 months, because the prostate can continue to kind of contract and change for that first year.
Sure.
Then at the year mark, you'll do an MRI. So I'll go back to Dr. Bush's office and do an MRI, and he'll look at, hey, here's where you were a year ago, the day we did your Tulsa. Here's where you are now.
Okay.
And some guys, unfortunately, they do say, okay, we see something else. Most don't. And then from there, it'll continue. I think you can go out to every 6 months on the PSA, still the annual MRI. After, I think, 2 or 3 years of an MRI coming back clean, you can go to every 3 or 5 years on those.
That's great.
So it's still lifelong monitoring.
Sure.
There's always going to be, in my opinion, once you get any kind of cancer diagnosis, there's going to be monitoring. You're going to monitor that the rest of your life.
Right.
So you're always going to be waiting for the next blood work or everything. But I'm not, I'm less apprehensive going into next week than I had been before I did the procedure. But there's not, it's not this big intensive, I'll go do blood work.
Okay.
So.
Well, that's fantastic. Yeah. And with my wife having had breast cancer, she absolutely detests the commercials on talking about cancer. So she just pauses.
And I don't mean that bad. We don't.
But you're going to have that diagnosis, and you're going to have that in the back of your mind your whole life.
Yep.
And so absolutely. I mean, why wouldn't you want to test and and monitor
and be in control again, controlling your own destiny?
Sure.
You're the captain of your ship. But I tell everybody I can, if you're not comfortable having hard conversations with your doctor that may sometimes disagree with that doctor and coming out of there still being friends, then you need to think about where you're getting your health care.
Well,
value your health care. Again, somebody in your earlier podcast before this one, they use the analogy of if somebody offered you a car for $3,000 and it was a really good deal, you wouldn't think twice about it. They've said, hey, you need to spend this $3,000 on your own health care, prevent this later on. The average person will say, I don't think so.
Yeah.
So, it's about making the right decisions. And sometimes those are tough decisions. But like you said to me in 2010, when I was way overweight and way unhealthy, how long do you want to live? And how much do you not want to be a slave to the system?
Yeah.
And if you just continue to do what they want you to do, feeding you full of whatever medicines or doing surgeries that alter your quality of life, oxymoron, right? Quality of life when they take it away from you because the standard of care dictates something that likely leaves you with
that
impacts.
Makes me twitch. Standard of care.
Mm-hmm.
I'm like, I think taking the ball and running with it like you did in 2010. And you know what? Sometimes, to kind of maybe pat myself on the shoulder a little bit, and that's kind of hard to do too. Some people may not think that, but I don't mind telling you the hard stuff.
Yeah. I called that Friday. I think it was Friday, August 9th. The meeting you and I had, I had come in for an ear infection, as I recall, but I had blood work done a little while before, and you looked at the blood work and you're like, how long do you want to live? It was kind of, but again, we have that kind of rapport.
We were in room 4.
Yeah. So
I can tell you where we were.
Yeah. So it's
crazy?
like, how long do you want to live? And it was funny. I tell this story a lot. When we left here, we went to the mall And I went to the cookie company and I said, I'm going to eat a cookie because this is going to be the last sweet carbs I have for quite a while.
Mm-hmm.
And I wasn't a runner ever before. I wasn't athletic. But I started the next week, so the year 2011, and luckily I work for a company that has gym facilities on site. In the year of 2000, from November, August of 2010 through the end of 2011, let's say, I averaged being in the gym 4 days a week or more. There were days that I was physically in a gym 6 days a week. I would drive to the gym on Saturdays. So I was running at the height of things. I got up to probably running 20 to 25 miles a week, eating relatively healthy,
Smoking cigarettes.
and smoking cigarettes for the first year of that. But then I decided, that I gave that up too. So now, so I've been, I've gained a little bit of it back, but not, not extreme. And I've not smoked in 15 years now. It'll be 15 years in a couple more months.
And I think that's where you and I can help you own your own healthcare.
Right.
Because I can just give you data and you can interpret it.
Yeah. And again, not everybody can do that, but I'm a researcher when it comes down to, again, once we had that, again, I'll go back to the Come to Jesus meeting. How long do you want to live? And by then my dad had already had his prostate cancer diagnosis. He was 4 years in. I was very unhealthy. I think I really started owning it at that point in time. Up until then, I wasn't tracking stuff. I wasn't watching stuff. I didn't know an A1C from a PSA from anything. But after that, it really kicked into high gear for me. And again, I'm just kind of a spreadsheet guy. I love Excel. I'll do anything I can in Excel. But I think anybody can find their own system for managing their own healthcare, right? You can, no matter what you do, you can find a way to control your own destiny.
And that's the beauty of us being the conductor of that.
Mm-hmm. Yeah. I think that's
and it
great.
doesn't have to be just me.
No.
I've tried to get, people looking at other, other providers that actually just allow you to make those decisions. Mm-hmm. I'm going to give you data.
Right.
I can keep the data in my spreadsheets, and you don't have to do the in-depth work that you did. It's helpful for me,
right?
But I can still look at it and go, I think you need to look at this.
Yeah.
Just like I told you yesterday, one of my buddies, good friend of mine, I was talking to on the phone, and he's got an issue with his prostate cancer. And I'm like, hey, I'm going to do a podcast tomorrow with a guy that he's our age, and man, I'm gonna dial in with you, and I'm gonna have him call you, and I want you to watch this podcast, and I want you to, he didn't have to keep up with all of that data, but he can talk with you, he can talk with me, he can talk with Dr. Bush or the local urologist. Right. We've got fantastic resources, and because I think we have the time to sit down and talk with you about it. The total length of this podcast has been some of the times we've been in a room together.
Yeah. Oh yeah. Many times.
Right.
It's not, and again, that's the standard of care you get here is very different than, I've never felt like a number here, and I've never felt rushed. Some doctors, it's almost like, and this from working other places before this. You need to see X number of people between 8 and 5. And so the clock stops, and you're just like running cattle through a chute. And I've never felt like that. And I think you got to get that feeling to really truly be, if you've got that feeling, you're not in control of your own destiny on your health. Yeah. And you need to figure out how you get there. And I think this is, what change you're trying to make in the system will benefit us all. We just got to
trust me,
more people bought in.
Right. We do. And I think people are understanding that because, I looked at, more than likely when I saw ear pain walking into a room, I was like, great, it's going to be something that's super simple. Mm-hmm.
Yeah.
And it turned into this long, hey man, how long you want to live?
Right. Yeah.
I've got another friend of mine. He's like, I don't go see Joe because every time I go see him, he tells me I'm fat and I need to lose 30 pounds. I'm like, well, maybe because you're fat and you need to lose 30 pounds.
But you spend the time to do it, right?
Yeah.
Your regular doctors don't care. A lot of doctors, and I don't mean this bad, but the system doesn't allow them to spend enough time with you to even know you well enough to
It's
care.
to actually tell them the truth.
Yes.
So I was listening to a sermon one time, and it was a very well-known preacher, and he said, one of the greatest ways to love somebody is to tell them the truth.
Yep. And that's hard. I mean, we find it hard in society as a whole.
Hard.
And especially if you are pushing against the system to tell somebody the truth, right?
Yeah.
And so, especially when the system's paying you. And so it's challenging. But, I think going through all this, I mean, I don't wish a cancer diagnosis on anybody. But especially when I think about prostate cancer, if you get that diagnosis, if you've not already started researching, you need to start looking, and work with your healthcare provider on what's best for you, not what's best and easiest for the system or for their schedule or for whatever. Mm-hmm. And understand that prioritizing your health and your well-being may mean that you have to make financial decisions.
Sure.
And, I just had to come to terms with that what I wanted to do to address this means, I treated my cancer. I didn't buy my Camaro.
Right.
But I'm going to have years to get that Camaro.
Driving your Prius.
Yeah. So I'll drive my Prius for, no, I'll never. I'll keep driving my Chevy truck. But the quality of life I have 3 months post that procedure, I don't feel like I would have had as
well. I will tell you, I love the transformation that you've made in your health and your well-being. I mean, you can actually still see it in your skin, like those telangiectasias, the red skin that you had before with the blood sugar issues and the smoking. And I was like, it's not there anymore. And it's really cool.
Yeah.
Like that's not supposed to go away. Right. So it's fun to have you explain this, dive into this. Hopefully we can help a lot of men out and women because this is a 2-part deal. And you have to have your wife on board because you're talking about a pretty big financial outlay because insurance doesn't cover it, for a Tulsa procedure. Yeah. But for MRIs, it's still a financial outlay, but I'd rather have an MRI than start poking on my prostate right off the bat.
Right. And the other thing that they do really well, that Dr. Bush does really well, is he doesn't ever just talk to you. Your spouse is involved in everything. Right. Because these types of decisions, anything that can impact that type of quality of life, he wants to make sure. So he's not ever just talking to you. Okay. If they called me, hey, where's Amy? They always wanted, so she was always, it was never just me and a doctor talking when we were doing this Tulsa. It was a family thing, which is good. So you're all bought into this, but you're making that informed decision, right? You're not, it's not being dictated to you. The whole other side of this is, so a lot of guys will watch this and think, so you for 6 years lived with cancer that you weren't treating. So how'd you deal with that, right? So, at first it was hard. And again, I think it was harder for me at first just because I found out as my dad was dying of prostate cancer. So a part of my mind was like, hey, idiot, that could be you. Do you really not want to treat this? So I had to, I can compartmentalize things, but you also have to have just somebody, whether it's your spouse is a great thought partner on stuff, but you also have to have other outlets, so my minister has always been a go-to on things like that. And again, as guys, we don't think about it, but it's also okay to go see somebody to talk to talk through things like that. Because you got to have an outlet, right? I mean, if you just sit and think about it, if you just sit and think about having cancer, it will consume you.
And your cortisol go up, you'll produce more cancer cells.
Correct. So, I think, so you got to have those outlets. And the good thing for me was I had gone through that journey of being physically unfit to being physically fit. So getting out, still doing the things that I like to do, being outside in the summer, going hunting, things like that. Just, you got to have mental health outlets so that just thinking about it doesn't drive you crazy. And that's different for everybody. And some people, it would be hard to sit and watch and deal with that for 6 years and not do something about it. Luckily, I could compartmentalize it enough because, again, I'll go back to I did enough research to know, hey, it's cancer, but I'll know, I'll be watching for the signs of when it's time to treat. It's not aggressive yet. So
Right.
I think it's just, where do you find yourself in that mental spot? And everybody's got to find an outlet for how they address that.
Well, I tell you what has been nice in my practice overall is having people who have gone through a situation, a diagnosis of something, and being able to, for me to either recall it and just say, hey, can I call somebody real quick? And just call them and just say, hey, can you talk to them?
Yep.
And just like, there's multiple times that with my wife, my wife's, it's been almost 12 years now. And there's times where we get a new diagnosis of a breast cancer patient. And I'm like, hey, Trish, can you run over here and talk to this person for a minute?
Yeah.
And it's really neat to be able to have that outlet and to have other resources to be able to say, like when I was talking to you before we started this podcast, I was like, hey man, I got a guy I need you to talk to. Absolutely.
Yeah.
Right. I mean, we're talking to everybody,
Right,
so you might as well talk to one other person. So it's really nice to be able to, to have a community of people that we can kind of Rolodex in our brains and go, hey, I've had this conversation before. I'd love for you to talk to this guy and look at his journey and see what you think, like ask him the questions, ask her the questions about these things and, and make an informed decision. And, you've done the research. Why do I need to do the research if you've done the research, right? Just give me some data. Right. It's kind of like what we're doing right now. Yeah. It's like, hey, we're trying to spit out a bunch of data so that somebody can, go, well, I can do an informed, decision on this. So I do. I think it's been really nice for me as a provider to have these resources and to have a life with you and to know your history and spend those long agonizing ear pain visits with you that turn into like super quality time. Yeah. And so I do. It's we've had some toe to toes, some chest to chest. And, I'm not going to do that.
But doing that at other doctors' offices, I likely would have been asked not to come back, right? So, I mean,
well,
the medical system
can do that to me.
Right.
I just ask you not to do it to my front staff. That's when I kind of get a little bit sideways. Yeah. You can do it to me all day long. I'm pretty. I tell people, I said, look, I've had football coaches chew me out enough to where you can't chew me out that much. No. Right? But dude, I'm tickled to death with your journey. I'm tickled to death with your health, and
me too.
And for you to be able to come and spend this time with us here at Genesis has been fantastic. Your bride's over here and, she's also been going through a lot of journey together. So I'll tell you what, from a cancer standpoint in my life, what cancer did for my family is it gave us perspective.
Mm-hmm. It puts everything, and watching my dad and my mom, is a breast cancer survivor. So, I had both parents, and it does put it in perspective. Mm-hmm. And what it helped me perspective was, though, again, it helped me want to be in control of what I could.
Sure.
But then understanding what I needed to let go of. And that's why I think, when you think about a cancer that you consider active, surveillance is one of the treatments, meaning you're just going to watch it and wait and see what happens. It's just it's very different than what we're taught. So you have to really be willing to do that, but you can't let it run your life. And I don't think I did. That's why, seeing you on a regular basis, watching things, but then living my life outside of that.
And actively surveilling.
Yes.
Yes. So
it doesn't mean stop living.
No.
It just means you gotta be, you gotta watch, but it's not, you should never stop living.
And do you know how much a PSA test is?
Nothing. If you really want.
It's like $4 to $6.
Yeah, it's not much of anything.
Right.
So, and it could save your life.
Yeah.
So
pay for your quality of life.
Yeah.
And don't allow your insurance company to dictate that quality of life.
Amen.
Thanks for tuning in to the Genesis Healthcare Podcast, empowering you to live optimally. Ready to take the next step? Visit thegenesisdifference.com today to learn more.